do week 4?
Yeah.
Okay. Sweet.
Let's just continue off where we left off last time.
Okay. Oh, it's this one. Oh, this week is so heavy.
Wait,
Yeah, no, this week is like sucks.
Okay. So last time we covered biotech as well as biotech
Hunter syndrome.
and Hunter syndrome. And that's basically everything, right? Okay. So we're starting off with psychiatry. So I'll share screen. Thank you. This week, like, I'm talking so much for week 4. It's ridiculous. That's all right. All right. Okay. All right. So psychiatry or medicine of the mind is one of those topics that you feel isn't that useful. And it honestly isn't that useful, except for a few small points. This week here, though, is not that useful. So essentially, we have a few models of illnesses, and it's essentially a history lesson about where we've come with psychiatry or our understanding of the mind. The main things to kind of take from this are the overall trends. So a long time ago, we used to think that we had like evil spirits and like bodily fluid imbalances. And then that covers like the first 3. And then we have a religious time where a lack of religion results in your illness. And then we kind of get into more of our biochemical processes, looking at the actual anatomy. And then that's how we have come to our understanding in the present day. As part of that, we still have like a few dodgy ones, notably Freud. Freud is a bit strange. They would have talked about it a lot. However, it's a bit of a strange theory. And then we have the most present model, which is the biopsychosocial model, which kind of looks at the interaction between our biology or our anatomy, our brain structure, that kind of thing, our psychological state, so what we're thinking, as well as our social environment, so what's going on around us, and how that influences everything and how they all interact with each other. Health is probably an overused definition by now, but the WHO definition, a state of complete physical, mental, and social well-being, and not just the absence of disease or infirmity. The main thing to take away from this definition of health is the weakness in this definition. So the fact that it says complete physical, mental, and social well-being is criticized because it's essentially impossible to have complete physical, mental, and social well-being. So for example, an amputee, for example, technically doesn't have complete physical health. However, if they're used to living like this, they have great mental health and great social well-being, you could probably consider them healthy, even though they don't fully fulfill the whole criteria. In addition, different cultures have different attitudes to what a full state of health actually means. And culture is just the patterns of beliefs that different people have. And this affects our health understanding, as well as how often we seek help, what treatments we think are most effective, and what we think causes these illnesses. So this varies from culture to culture. Generally, your Western culture is a lot more similar to each other. Yeah, let me just mute everyone. Okay, sweet. So generally the Western cultures will have a vaguely similar understanding of health, and then you get a few differences. However, it's still important to note that within the same country, you still have different cultures, especially in Australia. Okay, moving on. This is me again. Epithelium. So this would have been, I think it was a fairly nice lecture from what I remember, if you guys had the same person. But essentially your epithelium.
John Bertram. It's like the old guy.
Yeah, John Bertram. Oh, was it John Bertram?
Yeah, for epithelium.
Oh, yep. Yeah.
It was like active learning.
Yeah. So epithelium, it's essentially the barrier between the outside and the inside. So if you think about your whole body, right? From your mouth through your gastrointestinal tract all the way to the end, technically that is still the outside of your body. And that whole lining, as well as your skin on the outside, is what we call epithelium. And these epithelial cells are essentially turned in a certain way, and they have different structures on each side, depending on the conditions that exist around there. It's also important to note that they're avascular, and this means that there's no blood supply here, and they serve a few functions, which you'll see throughout these slides. So we just have a few characteristics and classification ways. So we can either have simple epithelium, which is a single layer, or we might have stratified epithelium, which is 2 layers on top of each other or more than that. We can also describe the shape of the cells, depending on what they look like. So squamous describes flat, cuboidal, cubes, and columnar columns. There are a few specific examples, and they're essentially just combinations of the previous words we used. Simple squamous, simple cuboidal, simple columnar, stratified squamous. Each of them are found in different areas of the body. You don't have to remember exactly where you would find each of them. However, it's kind of important to note the reasons why you might have a certain type of cell in a certain environment. And then we have a few histology slides and a few a few cartoons about what the cells might look like. So kind of gaining an appreciation for what the histology might look like. And I believe you guys will probably do quite a bit of histology either now or later down the track. Histology is pretty rough. So don't stress out too much if you don't get it, because it's not super high yield, I would say. It's just painful. Yeah. Okay, this is probably what the most important stuff is. It's to do with the different surfaces of the epithelium. And we can basically divide it into the top, bottom, and the sides. So at the top, we can either have microvilli or cilia. On the sides, we have lateral junctions, or it's kind of like glue. And then at the bottom layer, or the basal layer, that's attached to something we call the basal lamina. And we'll go into more detail about each of these 3 things. So on the top, this is what we call the apical surface, and it faces the lumen, or the empty space. So the lumen, for example, might be your intestinal tract or your esophageal tract, anything that's exposed to the outside environment, essentially. And we have 2 options here, either microvilli or cilia. These would have come up when we were covering microtubules and microfilaments and things like that. Microvilli, the main purpose that you should know is that it increases the surface area in your intestine and within your kidneys. So it helps the process of diffusion and osmosis. In addition, we also have cilia, and these are pretty large structures, and essentially they move substances along, particularly mucus, sperm, and ova, or eggs. Yeah, so that's the apical surface. We have 2 options. And then the lateral surface, we have these 4 different structures. So zonular occludents, or tight junctions, they're essentially like a ring around the epithelial cell. So it's like a gasket, or like if you had a ring, and it essentially stops molecules from passing through the cells. The way I remembered this was that the occlusion starts with an O, and the O looks like a gasket. Then we have zonular adherens. These wrap around the whole side, as well, similar to the tight junctions up here, except the function of zonular adherens is that they stick to other cells. Then we have macular adherens. These are very similar to zonular adherens, except they're only at spots. So instead of like a whole ring, it's just small little attachment sites. Then lastly, we have gap junctions. These are the ones that will come up the most in this year. And these allow for substance movement between adjacent cells. Particularly, this will come up when you do muscle cells, sorry, your cardiac muscle cells, as well as your cardiac physiology at the end of the year. This is what a picture of them will look like. So you can kind of gain an appreciation for the apical surface up here at the top, and then your lateral surface on the sides and your basal membrane at the yellow area. And things numbered 1, 2, 3, and 4 are your lateral surface structures. And then lastly, we have the basal surface. The main important one to take note here is the hemidesmosome, and it's essentially glue that sticks the epithelial cell to the basement membrane, which is called the basal lamina. The epithelia produce this basal lamina, and an important thing about the basal lamina is that epithelial cells shouldn't be able to travel through here. So this is important for cases in cancer because some cancer cells are able to pass through and therefore spread and metastasize. And then the last point of John Bertram's lecture was glands, or things that secrete substances, are epithelial derivatives, or they come from the epithelium. Exocrine cells secrete into the duct, whereas endocrine glands secrete into the blood. This will come very briefly relevant at the start of year 2 when you look at some of the internal organs. Okay, onto connective tissue. So we just covered epithelium and like the basal membrane, and now we move on to the connective tissue. And as the name suggests, connective tissue serves to connect or separate tissue. And it's found everywhere throughout your body except the central nervous system. And we have a few types listed here. Blood is a questionable one. You get mixed opinions. However, for the purposes of this year, we consider blood as a connective tissue. However, that's not the main focus of it. The main focus is the specialized cells and the extracellular matrix. And these two substances make up our connective tissues. And the function and the type of tissue depends on the ratio between these specialized cells and the extracellular matrix, as well as the types of specialized cells we have inside the tissue. This is just what a cartoon or a drawing of connective tissue looks like. So the empty spaces here represent the ground substance. It's kind of like a watery substance that doesn't really do too much. We have specialized cells, which are these purple dots in both of these images, and they give the tissue essentially its function. And then we have fibers, and the fibers are somewhat like a cytoskeleton, and they join everything together. Okay, so we'll talk about specialized cells first. The main thing to take away from here is the different types of specialized cells. So chondrocytes, osteocytes, adipocytes, and fibroblasts, and each of them produce their own type of connective tissue. They also secrete the extracellular matrix, so they make the surroundings that are around them. And that's very similar to how your epithelial cells will produce its own basement membrane. These specialized cells also come from the mesoderm, which may or may not be important. We didn't get tested on it, but it's probably useful to know in terms of embryology, which will come up later on this year. Okay, so we talk about the extracellular matrix that the specialized cells produce now. And we can split up our extracellular matrix into 2 sections, our fibers and our ground substance. So firstly, our ground substance is like this clear fluid, doesn't really do too much except for giving a few nutrients and some mechanical support. But the important part here are the fibers. And we have three types: collagen, elastic, and reticular fibers. And each of them are found in different areas and serve different functions. So collagen, it's the most abundant. It's really tough. It's really flexible. It's just generally very, very strong. Your elastic ones, as the name suggests, are elastic, so they'll bounce back. And then reticular is like a very delicate mesh. You could think of it kind of like the opposite of collagen, even though they are both classified as collagen. They're just different types of them. We can also classify our connective tissue based on how loose or how dense it is. And within dense, we can classify it under regular or irregular. So loose connective tissue, there's a ton of ground substance and the fibers are really loosely interwoven. Whereas dense connective tissues has a ton of fibers and very few specialized cells. And when we talk about the fibers, we can then classify it into regular or irregular. So regular, it means everything's lined up in parallel. And if everything's lined up in parallel, that means it'll only be strong in one direction. A good example of this are your tendons and your ligaments, are the things that hold your bones together and the things that hold your muscles to your bones. However, if the fibers are woven together like a mesh and are going in multiple directions, then you get multi-directional strength. Now, this is particularly important for your arteries because they have to resist the pressure that comes from your heart. So this is another image of regular dense and irregular dense. So you can see in regular dense, they're all in straight lines, mostly straight lines, whereas irregular dense, they're a bit curvy, they're interwoven, that kind of thing. Okay, so we'll talk about particular examples of connective tissue now. And the first one we talk about is cartilage. I would say the most important thing to know here is that it's avascular and aneural. So no blood and no nerves. And the reason I say this is the most important is because the fact that it has no blood supply and no nerves essentially means that the healing process of cartilage will be very, very slow and may not even occur at all. We then talk about different types of cartilage. It's not too useful. The ones that will come up later this year will be your annulus fibrosus, and you'll cover this when you start doing the musculoskeletal system later on in the year. Otherwise, you can just have a read of these different types of cartilage, but the main thing to take away from here is a lack of blood supply and a lack of nerve supply. This is an image of what it looks like. So you have your chondrocytes or your specialized cells, and these specialized cells will produce the extracellular matrix. Once again, different type of cartilage, specialized chondrocyte, and the extracellular matrix. And lastly, the same thing again, but in a different arrangement. We then have bone. So contrary to cartilage, bone has a rich neurovascular supply, or lots of blood and lots of nerves. From this, we can take that they'll repair fairly easily. The two different structures of the bone is also fairly useful as well, especially when they especially when they give you an image of a bone and ask you to identify what type of bone it is. So we have two different types, compact and trabecular. So compact bone, as the name suggests, is very dense and it's all together in one lump, whereas trabecular bone, it's that honeycomb bone appearance. And we'll have, oh no, there's no images. But we can kind of see what they're structured like. So in the center, we have all the vessels, your arteries, your veins, and your nerves. So this gives it its rich neurovascular supply. And then we have the osteocytes, which are these brown blobs, and these are your specialized cells. And these specialized cells will make the matrix around it, and this will make up these large circles called osteons. It's also important to note that these are in concentric layers, which kind of just circle out. So yeah, and that gives you the whole structure of your bone. So you can see it slowly zooming in on each level in this picture here. Yeah, and this is what we're talking about. The neurovascular supply will determine the ability to heal or the ability to regenerate. Okay, HEP. I think that's Heine.
Yeah, that's me.
Right, there you go.
HEP is so much fun, guys. We love HEP.
Does anyone have any questions about connective tissue? Otherwise, we'll move on to HEP.
HEP is high yield, the same.
Yeah, it is, surprisingly.
Yeah, unfortunately, it is high yield. So actually learn the stuff.
But most of it you can guess.
Yeah.
And also if you do practice exam questions, they like to recycle questions for HEP.
Yeah, they
a
do.
lot.
So the good thing about HEP is a lot of this is like common sense. Like if, you know, if they ask you a question about stress or something and like, you know, you just like use, a lot of this is just purely based on just what would you like to do in real life. Like it's not, a lot of this is just, anyway, Craig Hassett has a tendency to use a lot of statistics in his lectures.
If you want to win Kahoot this week, like make sure you listen to this part. Yeah.
I just got asked a question. Is HEP multiple choice? Yes, it is multiple choice. So thank God.
I got a question from someone before. Like someone was asking that why doesn't Craig Hassett upload his slides like before the thing? Like I think he just has a habit of doing that. So he does that for second years as well. No real way of going around it.
Also, he gets really salty when people don't like show up to his lectures because I think he like knows that none of us like his lectures. So that's also like why. Like he tries to not upload his lecture slides to force us to go to his lectures, but like no one does. So like you kind of feel bad for him, but also just HEP. HEP is just HEP. Anyway. Okay, let's go through this. So integrative medicine, it's actually a really crucial part of like, it's actually a really good way to approach, you know, treating patients and everything. So it's all about approaching medicine in like a holistic way. So you're not only just doing like clinical kind of medicine, which is like what we're kind of taught like in real life, you know, this person gets this drug, this disease is treated with this, but it's also taking into consideration that some patients are going to want to use complementary and alternative medicines. So the difference, so complementary medicines are used alongside your like conventional treatment, whereas alternative medicines, it's kind of in the name, it's offered as an alternative to actual conventional treatment. Yeah, and you will get like, you will get like patients that in the future, like that will like come in and say like, oh yes, I do use like this complementary medicine and etc. So some key statistics, 65% of Australians actually use complementary therapies. So that is a statistic. All of the statistics on the slides are ones that you should remember. Don't try and remember all of Craig Hassett's statistics. Like it's not feasible for you to memorize everything he talks about because you can see like he goes through like 50 studies per lecture and it's just not like, just don't bother memorizing that much. Just memorize the key bits. 89% of people use CAM for serious medical conditions whilst getting treatment from their doctor. However, 72% of these individuals don't actually inform their doctor. So it just kind of reveals the fact that patients kind of aren't that forthcoming with information about like complementary medicines, because complementary medicines and like alternative medicines have kind of a bit of like a publicity issue, you know what I mean? Like patients aren't that willing to actually talk about the fact that they might use them. And that obviously that'll have like effects. It might have potential effects. If your patient isn't actually willing to talk to you about that, it might have effects on like whatever drugs that you actually prescribe them. They actually might have issues. They might cause like unknown side effects. And so it's just about having respect for your patient when you're actually asking them about whether they use complementary therapies. So why patients like CAM? it's considered like more natural. Like you would have heard of like naturopaths and like homeopathy and whatever, all those like fancy weird names. Like it's considered like more traditional, holistic. Generally people think they have like less side effects than what we would use as like conventional treatments, so like such as like drugs, surgeries, which are in general like much more expensive as well. And why us as like medical professionals usually have concerns is that there's very like little literature, like medical literature and kind of experimentation that goes on with CAM. So we don't have much evidence surrounding it. So there's potential dangers, unknown side effects, because obviously everyone responds to things differently. So, you know, that's always something that we're concerned about. And it's usually poorly regulated between like different CAM practitioners. No slide. Okay, so these are the different modalities of CAM. You would have gone through this in the lecture, but I think this is just taken directly from the lecture slides. So it's you've got mind-body medicine, which is like changing mental state kind of thing. It's all about, you know, like the mind and the body, kind of like what we were talking about in like psych. So like meditation, hypnosis, relaxation imagery, biologically based practice. So that's like more of like your vitamins, your supplements, herbal remedies, etc. Energy medicine, I've never personally heard of anyone like using this apart from like Grey's Anatomy, like someone did, but like like never really heard of this. But like that's more about like manipulating energy within individuals. Craig doesn't go through this as much, so like don't really worry about that. And manipulative medicine, which is physical manipulation, so like chiropractors, acupuncture, massage, etc. Okay, so Essence, you should all know Essence by now because we've gone through it in Clin Skills. Craig Hassard would have gone through it as well. So just remember the acronym. It's actually really, really useful. You'll find when like you're taking histories, you're just asking about social history, just asking about your patient's life in general. It's actually a really good checklist to have just to make sure that you've got like all the aspects of someone's life kind of, you like remember to ask about everything. Yeah, that one's like just memorize the acronym, you'll be fine. So we have different levels of health prevention. So primary prevention is actually stopping a disease before it's established within a healthy person. So that comes from either managing risk factors, having lifestyle modifications, just making sure like your patient is leading a healthy life in general. It's usually very under-recognized and it's underfunded. So primary prevention comes from just like, you know, patients going to see their GP regularly, making sure just like checking in and just being healthy in general. But usually by the time that a patient actually presents to you in the future, they're going to have gone like past actually primary prevention, unless you've actually caught like their potential risk factors before they actually might develop a disease. Secondary prevention, so that's when the disease is actually asymptomatic, so no symptoms, but the disease is actually like the patient has the disease already. So secondary prevention is aimed at just early intervention and actually slowing disease progress. So you don't want it to get to like the very last stage of a disease and you kind of realize and you go, oh shit, like, okay, guess we have to like go through all of this like expensive treatment now. You want to try and get it as early as possible. So usually secondary prevention, that's just like lifestyle modification and just treating any early stage complications and just trying to get the disease under control as fast as possible. Tertiary prevention is basically you have established the patient has a chronic disease and they have presented with possibly severe complications. And tertiary prevention would just be like making sure that they're recovering, providing them with rehabilitation, just preventing them from developing any further complications, the ones they already have. Okay, so these are some like acronyms that are just like good to remember, like especially like the goal setting one. you'll probably like, I don't know how your tutes are running, but like you'll be made to like write like the HEP journals, and like it's always like good to like say like, oh yes, my goal is to drink like 7 glasses of water a day, and I will do that through this, and I achieve that? Like, you know, just like when you're writing your HEP journals, making sure like you like reflect back on these particular, like these few acronyms for behavior change. So goal setting, you use like the SMART goals. I think like everyone knows about the SMART goals. Yes, and what Zoe said, they actually are examinable. So like do remember them, because you do need to know the different like types of like ways people go through behavior change. So goal setting, SMART. So that's kind of, this is all kind of like self-explanatory. Behavior change is BASK, and changing habits is ADEPT. It's all mainly with like changing habits and stuff. It's mainly like ensuring your patient actually like perseveres. It's not like you don't just like change a habit within like a day. Like, you know, you have to actually like keep going at it. You have to make sure you persevere through it. And that leads us to the Prochaska Di-Clemente cycle of behavior change. You need to know this. This is another one. Like, you do need to know this one. If you don't know this, like, this is like what HEP is like all about, especially like the first few. And you'll go through it in your shoots in a lot more detail, and you're going to be talking about it a lot. And Craig Hassett will reference it a lot. It's also like referenced not only in this, but like I think it's in like HLSD, so like psych in semester 2, like refers back to the Prochaska Di-Clemente. So you do need to know this. It's pretty simple, like pre-contemplation, like thinking about, you know, what you want to change, contemplation, and like blah blah blah. Like, just know this cycle, because if you don't know it, we're all going to be really sad, because this is like the key part of HEP that you do need to know.
Just on that, there's a way just to remember it. It was PCPAM. So basically P, pre-contemplation, C, contemplation, and that just is a good, you know, mnemonic just to kind of summarize it all.
Mm-hmm. And I think that was it. Yes, that's it. Okay, any questions about HEP? It's kind of like HEP, but you know, there are still like things you do need to know. So screening is part of the secondary prevention. Where is it? This one. Okay, any other questions? Mainly, like, this is just a summary of all of like Craig Hassett's slides and what's like the key kind of points that you should remember. Okay, cute. Let's go tissues.
Okay, I'll share my slides. Okay, so integrative tissue metabolism is actually pretty high yield, and it's just looking at how the different tissues use energy. So we're starting off with adipose tissue, and adipose tissue is mainly responsible for storage of TAGs, and it's so after a meal, you just need to know that fatty acids are delivered by chylomicrons and stored as TAGs, and in between meals, there are hormones that signal the need for energy, so they mobilize these TAGs, and so 95% of the energy that comes from beta oxidation, and only 5% comes from glucose to meet energy needs during in between meals. Okay, so for skeletal muscle energy, at rest, muscles only use 20% of total oxygen, but during exercise, can use up to 90% in order to produce enough ATP. And so these muscle cells are specialized to produce ATP and can utilize any fuel source. So at rest, most of the energy comes from fatty acids through beta oxidation, and a small portion comes from blood glucose and a small proportion of ketones. The reason why you can use ketones is because ketones are produced during beta oxidation of fatty acids. And for when you're moderately active, glucose is the main source of energy, and it's from glycogen stores. So when you have short bursts of energy, you'll have your body uses creatine phosphate and ATP reserves at first. And it's because creatine phosphate produces energy really fast, and it phosphorylates ATP and makes it ATP in one step. So when you have high energy, or like let's say you're sprinting, or you first start off your workout, your body uses creatine phosphate. Then if you're moderately active, there's an oxidation of glucose from the liver, so that's aerobic respiration. So ketones, glucose stores, fatty acids are also used. So when you're extremely active, stored glycogen is the main fuel source, and undergoes glycolysis and becomes lactate, which enters the liver to be rejuvenated into glucose. So the reason why is because the muscle is lacking oxygen and fuels, and it occurs before the heart can catch up. So this causes an increase in heart rate and respiratory rate. And you also need to know about starvation. So during starvation, muscle protein is broken down into amino acids, which are transported back into the liver to be converted into glucose. So basically the aim of all these different things is to maintain blood glucose levels. Okay, so this is a very important diagram that you need to understand. If you look at the left graph, you can notice that ATP reliance decreases within seconds, and creatine phosphate use increases and peaks within the first 5 minutes. Anaerobic metabolism is used more at the start, but it starts to decrease until aerobic metabolism sets in and becomes the main provider of the energy. Like usually it's around the 40 minute mark or 45 minute mark. Okay, the right graph, at the start, during rest and shortly after, fats are the main source of energy, but carbohydrates see a quick peak in usage, but then they decrease over time. At the 30-minute mark, we can see that the use of carbohydrates and fats are almost equal. And after the 30-minute mark, we start to rely more on fats. And in the 45th-minute mark, energy needs are met by catabolism of fats, mainly. So another thing you need to take note of is that in the heart muscle, cells are continuously active and cannot undergo anaerobic respiration. So the heart has no energy stores. So the heart primarily uses fatty acids, especially after eating. And after a long time, the heart can also use glucose from the liver or ketones. So the brain has a high rate of metabolism, but no fuel stores. So it must have a constant supply. So the brain can only use glucose as a primary source, and during starvation, it can use ketones because only these can enter the blood-brain barrier. So normal conditions, glucose is used undergoing aerobic pathway, and during starvation, the brain will use ketones. Okay, so some extra notes that you can take note of is that while fatty acids cannot be used as fuel for the brain, during beta oxidation is broken down into acetyl-CoA, which is a precursor to ketones, so it actually plays a role. So you just have to note that fuels by itself aren't a fuel source, but are used by proxy. Okay, red blood cells. Red blood cells have no organelles, so they don't have mitochondria, so they cannot undergo aerobic pathways. They rely purely on glucose and can only undergo anaerobic pathways. So on top of the glycolytic pathway, red blood cells can undergo pentose phosphate pathway, but you don't need to know the details for that. And this is a good table to summarize everything that you need to know. So during rest, your skeletal muscles mainly use fatty acids with some ketones as well. Red blood cells always use glucose. Heart cells always use fatty acids, glucose, and ketones. And your brain uses glucose most of the time. And so the only difference you'll see is mainly in the skeletal muscles. So when you have a short burst of energy, your body initially uses ATP reserves, creatine phosphate for the first 5 minutes. When you're moderately active, your main source of energy would be glucose. And when you're extremely active, you start using your stored glycogen. And when you're in a starvation mode, you basically end up using your protein. So you have muscle breakdown. And for your brain, when you're during starvation, you use glucose, and on top of that, you use ketones. So just the stable, you just need to know the stable by heart, and that's basically the whole summary of integrative tissue metabolism. Yeah, I think we're done. So does anyone have any questions?
No questions?
Make sure you guys know this, because this is actually like one of the highest yields for the entire like Sem 1 exam.
Yeah, even though you guys won't have an exam, but I'm pretty sure you guys get tested at the end of the year on Sem 1 stuff. So probably out of biochem, this is like the application of everything you've learned, I would say. And therefore it's fairly important to know. Okay, so what we have left essentially is, that was all the week 4 content. So should we do the Kahoot?
Very quickly though,
Yeah.
I just want to show, someone asked about alcohol metabolism. To be honest, I don't really remember this well enough to explain it.
It's okay. I'm typing a paragraph.
Oh,
right
okay,
now.
good.
Yeah.
I'll just show you this thing. Can you see that?
Got to zoom in.
Gotta zoom in.
Well, for me at least.
Oh shoot. A bit yikes.
Yeah,
Hold on,
that's
let
good.
me move it to my screen. Wait, that's fine.
Yeah, that's good.
Yeah, you guys can screenshot that. It's a pretty nice diagram. Yeah. And then read whatever Jiting says. But I remember this was very helpful when I was trying to understand alcohol metabolism.
I think the main key issue with alcohol metabolism is to do with the ratio between NADH and NAD+. So I think that's what's everything that's basically in orange on the right side of the diagram is talking about, that whole ratio. Yeah, me neither. I don't really remember too much of this either. But if you're confused, it's probably due to the NADH and NAD+ ratio.
Yeah, and to be honest, like you can just remember like all the outcomes. You know, you get acidosis. Actually, that one kind of makes sense because you favor.
I still remember this, so I'll quickly go through it. Just very quickly. So first of all, high yield is what is the process of actually metabolizing the ethanol you consume. So ethanol is the alcohol, and so you go from ethanol to what is this word? Acetylaldehyde. Sorry, I can't read. Through the process of using the enzyme alcohol dehydrogenase. So this is the first step. This enzyme gets tested a lot as well. And this step, once again, we're consuming NAD+, and we are producing NADH. This first step already sets off the balance between NAD+ and NADH. Now we have acetaldehyde, and this is toxic, and our body wants to quickly get rid of it. So we then convert this acetaldehyde to acetate
Asian
via
flush, by
the
the way.
enzyme aldehyde. Sorry?
This is responsible for Asian flush.
Yeah, via the enzyme aldehyde dehydrogenase. So if you don't metabolize this toxin quickly enough, this is one of the reasons why you get Asian flush. Yeah, and so once again, this second step, we're consuming NAD+, so we now have a lower concentration of it, and we're producing NADH, so we have a higher concentration of NADH. And so the main reason why we need to know about this imbalance is this explains a lot of the complications or the side effects of consuming alcohol. So one of them is we have lactic acid acidosis. So this just means our body is producing a lot of lactic acid. And that is because the process of converting our acetate to acetyl-CoA to then lactate, this process uses up NADH. Okay, because we've now got a lot of NADH, our body's essentially trying to do whatever it needs to decrease that concentration down. So it doesn't really care if we're going into lactic acidosis. Our body just knows that we need to get rid of this NADH that we've just produced. So one of the pathways by which it can do that is to produce lactate. This results in lactic acidosis. Now, the second common pathway our body likes to choose to get rid of this NADH is the synthesis of fatty acids and triglycerides. Because once again, this process will consume NADH, and this causes hyperlipidemia. And the other thing that I don't think it's on this diagram, but one other thing that should come up in a tutorial is for people who consume high amounts of alcohol over a long period of time, their body, because they're always essentially intoxicated, this normal pathway up here is no longer enough to metabolize the ethanol. So the body essentially uses this second alternative method as well, which is called the microsomal ethanol oxidizing system, MEOS for short. And this occurs second because it has a lower affinity, so the body doesn't prefer to use this system. This occurs in the smooth ER, and this system does not need NAD+. Instead, it uses NADPH. And it also requires this enzyme called cytochrome P450. The reason why this system is bad, because you're thinking, well, it doesn't use NADH. Why doesn't our body normally use this system? Our body normally doesn't want to do this MEOS, is because one of the byproducts of this is what we call reactive oxygen species, so ROS for short. And these reactive oxygen species will severely damage our internal organs, namely our liver. So essentially what it does is, because they're reactive, they need electrons. So they'll rip electrons from any cell in our body, more specifically our liver, because that's where alcohol metabolism occurs. And after it rips the electrons out from your liver cells, this leads to oxidative stress. And essentially your liver cells will just undergo apoptosis, and you'll get damaged liver cells. So that's why a lot of alcoholics have bad livers. And that essentially sums up everything you will ever need to know for alcohol metabolism.
Wow, I learned so much.
I can answer
well,
how do hangovers occur? So basically, mainly it's actually from electrolyte imbalance. Yeah, so like if you take a lot of alcohol immediately without any water before, or like fatty foods, it'll lead to like immediate digestion, and that, like, you'll learn more about that later on, further on in the years. But yeah, basically it's mainly through actually being dehydrated and not because of the clearance. And once it clears too fast, like you'll learn in semester 2, because alcohol is a zero order drug, so basically it clears at a linear rate. So basically then therefore like your brain just like becomes, your entire body just becomes dehydrated basically.
Yeah, very nice. I will stop sharing my screen now. I thought that was more useful, but no.
Does anyone have any other questions?
Did we answer that? The one in chat?
Which one?
Elias's one.
Does acetate metabolize to acetyl-CoA before undergoing gluconeogenesis, or can it directly undergo gluconeogenesis? Acetate. I believe essentially everything goes back to acetyl-CoA before going off into another pathway. So I think that's my guess. I think that's what I remember about acetate. But if anyone knows better, Ting or Zoe, biochem
yeah,
people.
I think yeah. I think just go off that it becomes acetyl-CoA. Yeah.
Yeah. Yeah. becomes
Acetyl-CoA is
acetyl-CoA.
like the center for everything.
Yep. If in doubt, pick the one with acetyl-CoA. It's probably correct.
Yeah.
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 Okay.
Yeah, sorry, we're a bit rusty with our biochem. If you want a clearer answer, I think it's best if you ask your tutor.
Yeah.
When you get to your alcohol metabolism tutorial, I believe there definitely was one.
Yep. Yep. There's definitely one. Okay. So we can either do a recap of weeks 1 to 3 content, or we can do the week 4 Kahoot. Does anyone have any preferences?
They probably want Kahoot.
Yeah, that's what I'm guessing as well. Yeah, here
Yeah.
we go. Here we go. Here we go. Yeah. Okay,
Yeah.
Kahoot it is.
Kahoot.
David?
Wait, am I sharing screen?
Well, I don't know where the Kahoot is.
Oh, it's just in the RJ's one.
Oh, really? Oh,
Yeah, I've just made it on 7can.
okay. I'll bring it up.
Thanks.
I can screen share.
In the meantime, I'm like writing some posts about like random parts of medicine. So what is like an area that you guys want to like learn more about? It doesn't have to be like anything like you're learning right now. What is just something like you're kind of curious about?
If anything, probably not content related, right?
Yeah, so like if it's not content related, like has there been anything like you just wanted to find out more about or something like that? Because I'll write some stuff up. I'll do some research.
Like work-life balance, medical culture,
Pathway to different medical professions.
Yeah.
That's a mystery for everyone.
Pharmaceutical industry. Is weed actually bad for you?
Pharmaceutical industry. You'll actually get a whole HKS lecture.
Oh, yeah. It's actually a really good lecture.
Yeah.
I didn't like
HKS
it.
one.
It's a bit worrying.
Is
Actually.
weed actually bad for you?
Yeah, but that lecture comes
I
like
think it
in later
increases
weeks.
your risk factors for.
Or schizophrenia, man. Like,
Yeah.
it ain't good.
Wait, David, I can't find it on RJ's.
Okay, I'll do it.
It's almost that bad.
Yeah, the pathway post med school, like honestly, like bro, it's just
Bit of a mystery for everyone.
it's you get told like, oh, this is the structure, but it's also like everyone can take, you know, different all we know is that like we all become interns, right? And then it's like what happens after that, it's just like cute.
Yeah.
Yeah, and you like branch off into different pathways depending on which field of medicine you want to do. And
Yeah.
some of them kind of like go down similar pathways. For example, anestheticians and critical care, they start off going through the same pathway, taking the same tests before they finally split at the end. It's very confusing. I have a colleague.
I've kind of wasted too many hours like looking into this. So if you're interested, this is something like I feel I know a little bit more about. So I can give some insight.
Yeah.
Give me a second. I'm trying to get the thing up.
There are also a few things that like actual doctors don't know, because like the whole pathway is very mysterious, honestly.
Yeah, just know that you're going to become an intern first. You're going to do 1 year of like internship, and then you're going to become a resident. Usually people do 1 or 2. It's like 1 year.
A bit more than that.
Like 2 years. Most people do 2 years of residency.
Depends what you want to get into.
And yeah, it depends on what you want to do. Like if you want to do surge, then like
you'll be waiting for a while, but you get paid.
have fun with surge.
Wait. Where's the Kahoot? Wait, why is it not here? Did someone delete it?
Is it in drafts?
David, don't.
it in
Oh
drafts?
God.
No, like I'm sure I've done. Like I literally have it. Like I literally looked at it yesterday.
Is it in my account or your account?
Yeah, it's in your account.
Let me try.
I'll have a look.
Wait, it's not this one. Like it was literally here. Like I labeled it with 4. What is this? Like the questions are there. Like I already did the questions for
37 people probably came just for the Kahoot.
Oh, I feel what?
Soz, guys, we're just having some technical difficulties. Just the people who like joined.
Wait, where would it have gone? Like there's literally nothing else.
I think check your own one, David.
I don't have an own one though.
Oh.
Like I literally don't have one.
Oh shit.
You have the questions written up in the doc.
Yeah, like the questions is like all there. Like, and I was doing it last night. And it was all done. But
Worst comes to worst, we do our own timer and you just share screen for the doc. But then there's no leaderboard.
True, no leaderboard.
wait, I'm so sad. How is this not here? Like, Kahoot can't delete, right? Surely not.
Unless you press delete.
Yeah.
Oh
Dude,
gosh.
surely not. I wouldn't have pressed delete. I'm so sad. What?
Is it in the trash? Is there even a trash?
There's no trash.
There's no trash.
There's no trash. Oh no. How about
Why don't we just like go through the questions? There won't be a leaderboard then.
or we can go through weeks 1 to 3, like the really high yield stuff, while someone like smashes out a Kahoot.
All right, wait, I'll do it. Yeah. You guys do that.
David, I'll do it with you.
Oh, there's a recently deleted folder in Kahoot and you press restore. Someone said.
Wait, how do you do that?
Wait, how do
Recently
you do
deleted.
it?
There is none.
Oh
What
my
is-
god, David. David.
That's all right. We'll reconstruct it.
Should stay for 30 days apparently.
Should stay for 30 days. Yeah, David, take that crown off.
Yeah, David.
Oh, this is so sad. What is this?
Okay, let's go through weeks 1 to 3 then. And then we'll make the week 4 Kahoot right now.
Yeah.
And then we'll do that at the end.
Yes. Sorry.
Yep, sorry about that, guys.
Wait, I'll do it. It's all good.
Okay.
ScoMo. Okay. We'll probably only go through the really, really important parts. So we'll go fairly quickly, depending on how quickly we can smash the Kahoot out. But before we do that, does anyone have any like burning questions about any of the content going from week 1 to 3? Because if you do, this is the time to ask. And then we can go into a bunch more detail about it instead of skipping it over and then realizing afterwards. So chuck it in the chat or speak up. Either one's fine.
Oh, Krebs cycle and metabolism.
Biochem.
Ooh, yuck.
Do not
Guys, you
like
genuinely like don't need to retain that knowledge past like year 1. I wanted to say semester 1, but like semester 2 is kind of like you kind of still need to kind of know a little bit about it. But like after that,
Do you
like
though?
yeah, semester 2 is like a little bit iffy, like a wishy-washy. Like I don't really know if we need it. Like, see, the thing is, I can't even remember like any of the biochem we learned in semester 1. So, don't worry. It's just like it's a temporary thing.
Do we need to know exact energetics, number of ATP per process?
I think it's more so about comparing. So like you need to know that aerobic is better than anaerobic and something else is better than the other thing. You don't exactly need to know the exact numbers, but you need to be able to say which one's more efficient, which one's. Oh my god, my voice is so low. I'm so tired.
But I do think overall input output is still important.
Yeah.
Yeah. Which, correct me if I'm wrong, is 2 to 34.
Yeah, the electron transport chain's a bit iffy. Like,
yeah,
different people say different things. It's like from 32 to 34, 36. Some people even say 38.
Yeah, so if you're struggling with number of ATP, just know overall.
Gibbs free energy, like the delta G thing I think you're talking about.
No,
No.
we didn't get assessment.
Isn't metabolism super high yield or just interconnectedness of pathways? Semester 1 biochem is probably the main thing you're focusing on, unfortunately. But what in particular is super high yield as a part of metabolism? I would say the alcohol
great
stuff.
metabolic rate.
What was that, Zoe?
The great metabolic race, you need to know, like in the first 30 minutes you use this energy, like after 2 hours you use this kind of energy. That's very, very high yield, but it's very easy to use.
Yeah. So great metabolic race, alcohol metabolism, particular enzymes for some reactions. So your pyruvate dehydrogenase, your acetaldehyde dehydrogenase. I think your endogenous pathway and your exogenous pathway for LDL is also fairly useful. Yeah. Oh my goodness, so many questions. Okay.
Transcription and translation. I'd say you need to know it pretty well because it ties in with regulation.
Regulation. I don't think it's too. The main important thing for regulation of transcription and translation, as well as DNA synthesis or replication, will be covered later down the track when we look at cancer and how we might get mistakes there.
And pharmacology.
Yeah, and pharmacology. Yeah, definitely pharmacology, because you'll talk about like anti-cancer drugs, and a lot of them target your transcription, translation, and some target your protein stuff. Lipid metabolism.
Also, you need to know when it happens.
Yeah, when it happens, as well as HMG-CoA reductase. Super important enzyme. So important that I realized it made it onto like one of the, I think it was biology or chemistry exams in year 12 in one of the years. And it'll come up later on the year when you start doing pharmacology to do with lipid lowering medications. And it'll also come up with your atherosclerosis when you start doing cardiology. Fed and starving state, yes, important.
Yeah, so this ties in with like the whole great metabolic race and knowing what energy source you use in particular situations.
Yeah.
And you need to know like when you're not exercising as well as when you're at the different levels of exercise as well.
Cystic fibrosis and familial high cholesterol levels. That's an ICL topic, I believe, right? The cystic fibrosis isn't that useful. I don't think we even got tested on that. Hypercholesterolemia is important in second semester, I believe, when we talk about lipid lowering drugs. But for first semester, not that important.
But they may test it in the quiz. You know, like we have that integrated quiz.
Yeah, they could test it in the formative, the summit. I forget which one's which.
The CIP, like the comprehensive, the
comprehensive integrated.
Comprehensive integrative puzzle or something.
It's like
it's actually like pretty high. That's actually like pretty.
Yeah,
pretty
that
cool
quiz is actually like good. It's good stuff. How much about lipid transport? Definitely know your different lipoproteins, your LDL, HDL, chylomicrons, and your VLDLs. The most important ones would be LDL, HDL, and your chylomicrons. Know which one is good, which one's bad. The role of chylomicrons. And as well as what I said before, the endogenous and the exogenous pathways for LDL transport. Yeah. Anything else to add on?
Do we just want to like run over the exact steps for and exogenous pathways. I feel like a lot of people are like have questions for lipoproteins, all that pathways, whatever.
Yeah, let's do that.
Yeah, I don't mind doing it.
Yep. Okay.
Do we have okay.
Week 3, I think.
Okay, I'll just okay. How do I need to work out how I share screen, how to split screen so that I have my notes in front of me, because I will not be able to do it without my notes.
Do you want me to share screen? I can share screen and you have
no,
notes.
it's okay. I've got. Do you have that like that diagram that Noma's got? That like fancy.
Oh, it's a beautiful diagram. It's actually
That
like
Guys,
the best
Noma
diagram.
is a queen. I love Noma.
Yeah, like, do you guys have that fancy diagram? You have that fancy diagram.
wait,
I just
I
need
have
that
it up.
diagram.
Which one?
Just answering Nathan's question. Oh, where'd it go? About atherosclerosis. No,
Yes,
that'll be
that
covered.
one.
Atherosclerosis will be covered in second semester.
Can you make it a bit bigger?
We're just mentioning it now because it's like an interlinking of semester 1 and semester 2. Movement of lipoproteins, exogenous, endogenous. Yep, endogenous, exogenous, and the reverse pathway, which is all kind of going to be covered by Jiting now.
Okay. Okay, do you guys want me to type out like the steps of the pathway into the chat as I talk? Is that like recorded, the chat?
Yep, chat's recorded. Yep.
Okay, I will type out the steps. Okay, how do I position? 1 second. I'm not that good at technology, in case you haven't realized. Okay, so let's go through the exogenous pathway. So the exogenous pathway is how our body deals with fat that we've ingested, so our dietary fat. Okay, so the first step, when the fat comes into our mouth, it has to be digested in our body. So hopefully everyone still remembers that fat droplets are too big for our lipase to get to. So the first thing, that fat needs to be emulsified by bile into these smaller fat droplets, which then become micelles. And this allows for lipase to then break it down via hydrolysis. Okay, so that's the first step of what happens to fat after we ingest it. So this is the exogenous pathway, what I'm typing right now. So the second step is that after it's been hydrolyzed by our lipase, we now have, free-floating fatty acids. We've also got glycerol, and these will enter the enterocyte, where it is first made back into triglycerides. It's made back into triglycerides and then packaged again into chylomicrons. So it might sound confusing. First, we've got to break it down by lipase into our individual fatty acids and glycerol. This then allows it to diffuse, because it's so small, diffuse into our enterocytes. When it gets into our enterocytes, our body will then form triglycerides again. This is because triglycerides can then be packaged into chylomicrons. Okay, so the chylomicrons then enter the blood via the lymph. So that's the next step. So now it's in our blood vessels. So in our blood vessels, the lining of our blood vessels, we also have the enzyme lipase. Okay, so we also have lipase on the lining of our blood vessels. So as your chylomicron kind of runs through your blood vessels, the lipase there will then break down the triglycerides into, once again, free-floating fatty acids and glycerol. Okay, so it's broken down again. And then our free-floating fatty acids are then able to distribute and diffuse across into our tissues, where our tissues can then use these fatty acids for energy. So not all the fatty acids are taken up by our tissues. Not all the triglycerides are broken down by the lipase. So we will have leftover tags we might also have some leftover cholesterol and glycerol in the chylomicrons. So we'll still have leftover chylomicrons. And these will form, because they're remnants, they're left over, they form what are called chylomicron remnants. And these chylomicron remnants are then transported back to the liver to form a cholesterol pool. Okay, so I will quickly highlight these steps diagram right now. Okay, so
Wow.
oh,
Can you still see it?
oh yes, okay, now I can still see it. Yep, so we've got our dietary fat, as we just said. It combines with bile to get broken down so that our lipase can then get to it, hydrolyze it. Now our free-floating fatty acids and glycerol can now diffuse through into our enterocytes in our intestine. In our enterocytes, they're now repackaged back into tags or triglycerides. These triglycerides will, sorry, is someone deleting my annotations? No? Okay. My annotations just disappeared. Oh, why are they disappearing? Can you guys see my annotations? Oh, okay. Can you see that?
I can't see anything.
No.
Can't see. Oh, why? Can you see that line I just drew? Oh no, it just disappeared from me.
No,
This
I
is
think
so weird.
I think if you go to like, you know how it says at the top, you are viewing Zoe's screen,
Yeah,
like view options and then annotate. Is that what you're doing?
yeah, that's what I'm doing.
Oh.
Oh, Zoe. Oh,
Oh, Zoe, you're drawing on the other screen.
I'm drawing on the other screen. Okay, never mind. How do I draw on this screen?
Hold on. You share this.
Do you have two screens, Zoe?
Yeah, I
Yeah.
have one.
Sorry, guys.
Guys, we love technology. We're really good at this.
Is it possible to reshare it or just let me annotate on this screen? Can you see that line? Oh no, you can't see that line. Oh no, this is giving me bad feelings because it's stuff I haven't learned yet. Okay.
I think I know why. Wait,
You think you know why?
Get out of this. Bam.
Oh, okay. Okay. I will quickly clear. Oh, I will clear. My doesn't line up anymore. Okay. Okay. Can you guys see? Can you guys see me circling dietary fat?
Yes.
Yeah. Okay. 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 So once again, exogenous pathway. So it's for the fat we ingest, which is our dietary fat. Whoops. So first step is we've got to combine it with our bile because our fat droplets are too big and our lipase can't get to it. Okay, so it's broken down by bile into these smaller fat droplets or micelles, and then it's able to get hydrolyzed by lipase. After it gets hydrolyzed, we have fatty acids and glycerol, okay, which is what we get after we hydrolyze a triglyceride. These are then able to diffuse into the intestine, into enterocytes, okay, which are liver intestine cells. So in the enterocyte, our fatty acids and glycerol, they're repackaged into triglycerides. So our body puts them back together again, okay? Extra work for our body, but it does that because triglycerides are then able to be packaged into our wonderful chylomicrons. After it's packaged into a chylomicron, which has a lot of triglyceride content, this will then go into our blood vessels via the lymph. Okay, so as I said before, within our capillaries, within our blood vessels, on the inner lining, we also have the enzyme lipase. So as our chylomicrons are traveling through this capillary, it's slowly getting broken down. So the triglycerides in there are slowly getting broken down again into fatty acids and glycerol. And these fatty acids and glycerol are then taken up by our tissue. So for example, they could get taken up by a muscle cell over here. Of course, not everything in the chylomicron is going to be hydrolyzed and taken up by our tissues, we'll have leftover stuff. And this leftover stuff has a brilliant name which tells us exactly what it is. These are our chylomicron remnants. Okay, so our chylomicron remnants are a result of our dietary fat intake from our exogenous pathway. And as you can see, this line tells us that this now makes its way, it's transported back to the liver where it's deposited into our cholesterol pool. So in our liver, we essentially have cholesterol that is there. One reason we have cholesterol is because cholesterol is needed to make our bile. Okay, so that's one reason why we have cholesterol in our liver, because we have to make bile. Okay, so moving on. So that's the whole pathway, the whole loop of what happens to fat we ingest. Next, we have our endogenous pathway. So once again, I'll type out the steps. Hopefully that's working. So as well as getting cholesterol from our chylomicron remnants from ingested dietary fat, we also have internally synthesized cholesterol. Okay, so for any cholesterol that our body synthesizes itself, it will be transported across the body through the endogenous pathway. Okay, so it's for internally synthesized cholesterol. So the first step is we'll consume, let's say, a bunch of carbohydrates. Okay, so we've just consumed, normally consumed excess carbohydrates. These carbs will be converted to acetyl-CoA to make more cholesterol. Okay, so that's the first step. We're making more cholesterol because we've consumed excess carbohydrates. Now, this cholesterol is then packaged into our very low density lipoproteins, so VLDLs. Okay, so that's the first thing they're packaged into. Now, VLDLs, once again, will travel through the blood via capillaries. Okay, so they too enter the blood system. Now, once again, as we said before, on the inner lining of our blood vessels, we have the enzyme lipase there as well. So once again, lipase lining the blood vessel hydrolyzes the triglycerides in our VLDL, okay, as VLDL travels through our capillaries. So what happens is, as the VLDL is traveling through the capillaries, the tags are getting hydrolyzed by lipase. And as more and more of these triglycerides are hydrolyzed, the type of lipoprotein changes. Okay, and why does it change? It changes because we now have a decrease in our triglyceride content. Okay, so as we said before, the type of lipoprotein mainly depends on the amount of triglyceride versus the amount of cholesterol. We've just hydrolyzed the triglyceride because of the lipase in our blood vessels, so our triglyceride contents are decreasing. As this triglyceride content decreases, we'll change the type of lipoprotein we become. Okay, and this change is we go from a very low density lipoprotein to an intermediate density lipoprotein, so IDL, not important, I just thought I would mention it, and ultimately to become an ALDL, so a low density lipoprotein, okay, because we've decreased the triglyceride content. So the next step is, so in our bloodstream, we now have, instead of VLDLs, we now have LDLs, okay, and LDLs are, as we said, the bad guys, and our body wants to get rid of it. So one way our body gets rid of it is via our wonderful cells, macrophages. So one way is LDL is then phagocytosed by macrophages. Now, unfortunately, macrophages essentially have a capacity, so they have a limit to how much LDLs they can phagocytose. So if they overwork themselves and they burn out, like us, they'll become foam cells, okay? So macrophages become foam cells once they reach their capacity. And the reason why foam cells are really bad is because, one, they can't do what a normal macrophage does, okay? So we've essentially lost it's essentially lost what it's supposed to do. It can't function anymore. The second reason is foam cells are kind of really sticky. So they can stick to the inner linings of the blood vessel, and they can kind of stick to each other and form like a clump. And then we can have blockages in our blood vessels, which is not what we want. Okay, so that's why foam cells are really bad and we don't want them. And that's also why LDLs are really bad, because they produce foam cells. Okay, so of course our macrophages, they're not almighty, so they can't phagocytose every bit of LDL we produce. So any excess LDL is then transported back to the liver via the receptor-mediated channels, so an LDL receptor, essentially. Okay, so once again, I will show you these steps on the diagram. So once again, if you look back to our cholesterol pool in our liver, okay, so we've consumed excess carbohydrates. The carbs are converted to acetyl-CoA to make more cholesterol. Now, this cholesterol is then packaged into our VLDLs. Okay, so if you look at number 5 here, they're packaged into VLDLs. And as we said before, they too will enter the bloodstream. In the bloodstream, we have lipase lining the capillaries. And what does lipase do? It will hydrolyze the triglyceride as the VLDL moves across our blood vessels. Okay, so as the triglyceride content decreases, our lipoprotein also changes. So it goes from a VLDL to an IDL, ultimately to the bad guys, our LDLs. Okay, so one way our body gets rid of these LDLs is through macrophages, okay, which can phagocytose any excess LDL we produce. Unfortunately, as we said before, once they hit their max capacity and they burn out, essentially, they become foam cells, okay, which can stick to the inside of your blood vessels and cause blockages. Any excess LDL, however, okay, is then transported back to the liver. So if you look at, follow the line of number 9, I believe, it'll then go back into the liver via the LDL receptor. Okay, so the LDL receptor is used for returning LDL that we've produced through the endogenous pathway. Okay, anything else? Okay, and then I probably should talk about this reverse cholesterol transport up here, which is also kind of important because that's where our HDLs come from. Okay, so I'll quickly type out the steps for reverse cholesterol transport pathway. Okay, so which is the purple lines at the top here. So as we said, there's cholesterol in our liver. Now, not all of the cholesterol is converted into VLDLs, okay? So some cholesterol in the liver is converted into HDLs. Yay, okay? So we do make HDLs within our body, so the good guys, okay? So HDL will then travel through the bloodstream and it'll esterify any cholesterol that it comes into contact with, converting it to a cholesterol ester. Okay, so it essentially decreases the amount of LDL for us, which is exactly what we want it to do. And it's good to note that during this process, nascent HDLs become mature HDLs. So once it's done its job and it's esterified the cholesterol it comes into contact with, it essentially matures. So now that it's made it into a bunch of cholesterol, our HDL will then transport this to the liver via the LDL receptor and the SRBI receptor. So it can use 2 different types of receptors for this process. So for transporting excess cholesterol out from our bloodstream back into the liver. Okay, so quickly I'll just annotate that on the diagram. So once again, looking back at our cholesterol pool in our liver, if you follow this arrow here up to number 10, so some of the cholesterol is converted into HDLs. And then this HDL will help us undergo the reverse cholesterol transport pathway. So it'll go around, it'll travel through the bloodstream, so it enters the bloodstream, and any cholesterol it comes into contact with, it's going to esterify it and convert it into a cholesterol ester, okay? And during this process, our nascent HDLs mature and become mature HDLs. So after it's done its job, it's going to then transport this cholesterol back to the liver via either the SRBI receptor, so number 12, or it can also use the LDL receptor as well. Okay. Was there anything else for lipid metabolism? Do we need to go through cholesterol uptake or not? Nope. Okay. And also, just a quick note, very high LDL cholesterol levels is what leads to plaques in your blood vessels. So as I said before, because foam cells are sticky and they stick on the inside of your blood vessels, and this is the beginning of atherosclerosis. Yeah. Okay. Guys, anything else that was part of this process? I think I've covered the diagram, so that should be it, right?
Where is serum albumin used?
Serum albumin.
Yeah.
Is serum albumin?
I don't think it's used.
Oh, okay. Albumin. I think. Do you mean albumin, which binds to fatty acids in the blood? Right. Okay. I think I'm a bit rusty. You might want to double check because seriously, rusty. I think that is when you want to mobilize fats. So that's when like glucagon binds to a receptor on adipocytes, and it essentially initiates a bunch of events to essentially mobilize and allow our body to then have access to fatty acids again. When that happens, when glucagon happens, a cascade of events occur, and it will activate the enzyme lipase, which we know will cleave triglycerides into fatty acids and glycerol. Fatty acids can then diffuse and bind to albumin in the blood. And I think albumin just essentially helps to carry the fatty acid to the destination. Yeah, and fatty acids will then be able to enter the cell through the fatty acid transporter, and albumin, when it gets to the destination, will release the fatty acid into the cytosol of the cell. Yeah, so it just helps transport fatty acid from adipocytes to the destination of wherever our body needs more fat, if that makes sense. Yeah. Yeah. Sorry, there's a question. One sec. Don't worry, you guys continue.
Alrighty, I'm going to sleep. It is half an hour past my bedtime. Goodbye. It was nice.
Bye.
Bye.
Bye, Zoe.
Bye.
Good night. Stay safe. All right.
Jiting, how do you remember all of that stuff?
Yeah, that was amazing.
Jiting,
Thank you.
you're going to be at the new Khan Academy, I swear to
Yeah.
God.
Oh yeah, by the way, a good way to remember all like everything that Jiting just like, I don't know, pulled out of her head.
How?
I think the best way really is to like, I don't know, either print out the diagram or have it on your screen or use your iPad or whatever, and like explain it to yourself, or like basically do what Jiting did, but to yourself or to one of your friends over Zoom or something like that. I think that's the best way to memorize.
Yeah, do you guys see like the huge whiteboard in my background? Yeah, like what I would do is I'd grab like all my soft toys and I'd like sit it on the floor and I'd like pretend to give them a lesson. Like that's how I learned my stuff.
Yeah.
Yeah.
Whiteboards are amazing. Bit expensive, but yeah. Well,
Yeah.
not really, but yeah. Cool. Does anyone have any last questions? Otherwise, we'll get started on the Kahoot, which David has like smashed together in record
Yeah.
time.
Thanks, David.
Otherwise, get Kahoot up. Hope you were paying attention during HEP.
Yeah.
Yeah.
Because this lipid whatever stuff is not on the Kahoot.
Yeah,
Is
this
it on
is
the
all
Kahoot?
week
It's not
four
on the Kahoot. Yeah.
This is all week 4 stuff. No. Who wants to share? Can someone else share, please?
I can share.
Thank you, RJ. Thank you.
Mhm. Oh, Peter, I think you need to let me have co-host.
Oh, are you not? Oh, because you rejoined. Right.
Yeah.
There you go. There you go, King. Oh, Jenna comes back. Jenna Talia. Ah.
Oh yay!
HEP is important. Nice. All right, we can get it started, RJ.
Okay.
All right, let's go.
Okay, that's pretty good.
Yeah.
Who's explaining these questions? Okay, nice. Okay. Yep. So a vector is essentially a mode of transport that you use to get DNA into another organism. So a plasmid, those are your circular DNA things, like Cheerio-looking things that you stick into your organism. Virus is a virus. An artificial chromosome is as the name suggests. Restriction enzymes are not, because they are the ones that cut DNA.
Okay, moving on.
Ooh, run.
Nice. So a vector needs a restriction enzyme site or a recognition sequence, essentially because you need to cut the vector at a certain area in order to insert some new DNA there. So you must have at least one recognition sequence. You also should have selectable markers to identify the presence of the vector. Otherwise, there's no way of knowing if the organism has been successfully transformed. The reason why you don't need two origins of replication is because one is simply enough. Having an extra one is somewhat redundant in this case.
Okay.
Nice. So option red, or the triangular option, to cure a certain disease in following generations, that refers to when we change the gamete artificially. When we change the DNA of the gamete. That one's not legal, by the way. That's the only one that'll the effects will be seen in multiple generations because you affect the gamete. Blue, harvesting synthetic organs, one, not legal, and yeah, just not legal. Synthetic organs aren't a thing yet, unfortunately, or fortunately, I don't know. And then to identify genetic disorders, that's not the purpose of farming. Identifying genetic disorders is through testing and screening. So yeah. Yeah. Right, so the reason why elongation is not a step is simply, it's just a different word we use, I think. Elongation refers...
We use extension.
Yeah, we use
not
the word extension.
Elongation.
Elongation refers to, I think, transcription. Yeah, it refers to the process in transcription.
Yeah, I just read this question because like when I did it, I got elongation wrong. I kept thinking back to central dogma instead of like PCR.
Yeah, denaturation is where you separate the two DNA strands to get access to the bases. Annealing is where you connect the Okazaki fragments together, and extension is the process of making the new strands. So yeah.
Is it Okazaki fragments?
Yeah, pretty sure, because still DNA replication.
Oh, okay.
Yeah.
I thought it was just short primer strands, whatever. Oh, but you guys do need to know the temperatures for this. Yeah, adding primers, yes. Yeah.
Right. Yeah, so forming all somatic cells, so your 3 germ layers as well as the developing embryo, that's pluripotent. Yep, so that is kind of, yeah, that's your best one. Polypotent
That's not a
isn't,
thing.
it's not a thing. That's just
not a
David
thing.
messing with your head.
I needed another like answer, so I just
Yep.
put that in.
And totipotent, oh crap, what does totipotent refer to, guys? Totipotent, totipotent can result in like everything.
Yeah, also.
Yeah.
Yeah, like including the placenta, things like that. Yeah. So what is true about gene therapy? So it's not option red because gene therapy at this stage is only to somatic cells and not your gametes. So that means it's not permanent.
No. Gene therapy is not permanent because you're just introducing like a new allele, which and when that new allele produces the required proteins to cure the disease, one, the allele's not permanent, and two, the proteins will get degraded over time. So yeah. Not permanent. It's not mass produced because a lot of improvements still need to be made. In fact, there actually are manufacturing problems right now, so it's not really used. And does not require the usage of recombinant DNA. No, we do. We do need to use a recombinant virus to act as a vehicle to infect the patient. So it's essentially we give a patient a virus with the healthy allele. We get it into their body. So then this virus can essentially almost hijack one of the patient's unhealthy cells with the unhealthy allele to then introduce the healthy allele into the cell. Yes.
Okay, next one.
AIDS on fire. They are.
So what is false? So which one's incorrect? It basically occurs almost exclusively in males because I believe it's X-linked, X-linked recessive, I believe. So therefore,
yeah, it's X-linked.
Yep.
Yeah. So basically,
yeah.
The way you remember is like think about like hunters and gatherers. So basically, hunters and gatherers. Like the guys usually hunted and gathering berries were like often the ladies. Like it's not sexist, it's like fact. So, so this is it. Yeah.
Yep. Sweet. So we were covering this. Epithelium is actually avascular, so no blood supply. The blood supply is given through the basement membrane. Epithelium is found in the blood vessels because it lines that surface. Cells are polarized, so they have the different surfaces, your apical, lateral, and basal surface, as well as them forming a strong barrier, which is kind of like linked to your innate immunity and your intact skin.
Ooh, AIDS.
This one's kind of just being familiar with your histology. Yeah, can't really explain this one, I think, unless anyone has anything to add.
No.
Ah, yes, remember, urinary tract. Not going to say why.
So desmosomes are found on the outside as well as macular adherens. Gap junctions don't hold, they kind of act as a tunnel between separate cells. Yep, so ground substance, if you imagine it to be a watery substance, it doesn't really make sense for a water and a fatty acid to be combined together because they won't mix that well. And yeah, water and glycoproteins, although it contains that, it contains extra things, macromolecules in particular. Nice. So adaptive cartilage, yeah. Elastic cartilage is like one that you find in your lungs, so it bounces back to stretching. And then hyaline cartilage, I believe, is found in like your articular surfaces for your bones. Yeah, so it is a type of cartilage that kind of covers your bones to prevent damage. Yep, so which is not true or which is false about bone? Bone is highly vascular. Yeah, bone, the specialized cell is osteocytes. There are two types of bone, trabecular, which is like the spongy bone or the honeycomb appearing bone, and the compact is compact. And yeah, bone healing or any healing does depend on time and the neurovascular supply. This is one of the facts that you should know for the exam or any assessment purposes.
Sorry, this is meant to be a percentage. Yeah, good, good, good.
Oh.
Nice. Everyone got this.
Oh,
Very
nice.
good, very good.
I am impressed. Good job, guys.
Yeah.
Everyone actually listened when I said. Wow.
Yeah, just know the facts. But even then, I don't know the fact here, so you can take how relevant it is in year 2 then.
I run so fast.
Yep, another fact. This is why David told all of you to pay attention during HEP, because it's clearly paying off here. So good job. This will carry you in your exam. Yeah, so primary prevention is essentially everything about primary prevention is managing risk factors and changing your lifestyle. The thing about primary prevention is that it's not funded that much, which is a bit unfortunate because it's probably the most effective one.
Yeah, so this, you just need to know that when you first start working out, you use creatine phosphate for at least the first 5 minutes. Yeah, so basically, yeah, most of you got it right. So during starvation, your body tries to use all your reserves first before they start breaking down amino acids and cause muscle breakdown. Okay, you need to know this because your heart cannot store energy. It always uses fatty acids and glucose and sometimes ketones, but it'll never use amino acids. And it also doesn't break down. It doesn't, like during starvation, your heart doesn't undergo muscle breakdown, so it won't use amino acids.
That's a real picture of David. That's a lot.
All right.
They're all right.
Nice. Good job to HEP, right? Is it HEP? Yeah.
Yeah.
Go ahead.
Very nice.
Yay!
Clearly pays off.
Wow. 19 out of 21.
Yeah, nice. Sweet. Cool. Does anyone have any questions from the Kahoot or any questions in general? Yeah, any questions?
Any questions in general? Also, quick question. Do you guys want us to like maybe do another session for week 5 content to get you guys ahead, or are you guys like, nah, we just want to revise?
Yes, yes, yes. Oh, best way, or at least a good way to sort out your notes.
This is totally up to you. Like, I know a lot of people use OneNote. I hate OneNote.
A lot of people, okay, fine. No, I can't say a lot of people because it's, I don't know who uses it, but I switched to Notion this year.
So many people are using Notion now.
Notion is like a power
Notion
tool.
gang.
Notion is actually like a power tool. Check out Ali Abdal.
Yeah, no.
If you want to use Notion.
Notion's good.
Yeah. Oh, it's actually amazing. Like, I didn't like it at the start. It's a bit of a learning curve, but it's pretty nice. I also hate OneNote.
Oh yeah, it's such a learning curve.
Yeah.
Yeah.
Also, how do you guys feel about these?
I'm not good at technology, so I don't use Notion.
Yeah. Also, just to everyone else, how do you guys feel about these nighttime sessions? Like from 8 to 10 o'clock? Because I don't know if it's too late, like if you're tired by the end of the day, or if you prefer daytime sessions or weekends or something like that. And if you don't want to chuck it in the chat, chuck it on our feedback form, please, which is also in the chat. I would love that, like, please. Yeah. Does anyone have any other questions or like
Self-validation?
Any concerns?
Oh, we forgot to mention the Club Penguin before people left.
It's
Oh,
fine.
yeah.
The people remaining are the true ones.
Tea.
Oh no.
Yeah, do you want to tell them, Hein?
So, we don't know when this is happening. This is a very, we started playing Club Penguin
After everyone left.
After everyone left last week. Because we thought like PS Pingu, like why not Club Penguin? So like we were playing Penguin. So if you want to come join us play Club Penguin one day, we'll do like a games night or something, just like chill. But yeah, I don't know when we're going to do it. It's probably during Midsem, sometime during Midsem. So like by the end of this week. But yeah, everyone come join us, play Club Penguin. Everyone has like a premium like member account. So you can adopt as many puffles as you want. Just like really relive those like primary school memories. But yeah, it'll be really cute.
Yeah. Otherwise, any questions? I'm like guessing not, because I've asked like any questions 5 times now. But yeah, this recording will be up on the Google Drive probably by like either late tonight or tomorrow morning, as well as the chat. And then the week 5 slides are already up on the drive as well, if you really are keen. Otherwise, week 1 to 4 slides are also up, as well as all the topical slides. We also have the OCE medical interview thing, as well as the practice questions from today's Kahoot will also be going up tonight as a Word document with the answers. And I think that's everything up on our drive, unless we suddenly make something up and then upload it. But yeah, anyone got anything to add or any questions? Finally.
Question.
Yeah. Okay. I'm gonna shut up. Yeah.
Where can I find practice questions for just practice content? Because maybe just lecture slides.
Have you guys gotten the progressive quizzes yet on Moodle?
Is it the 45 questions?
Yeah.
Yeah, those are pretty good actually.
They
Yeah.
use some of the questions from there, like on your actual exam. So just do them a few times. I'll actually know the answer for every one of them.
Yeah. And once you get closer to like SWOT back, they'll actually give you like they'll give you access to like past exams. And then a lot of the other like because I think maybe a kill has them or something, but like the other PSPs will start doing it too. Like we'll start like churning out like revision questions based on like topic. It's just like a little bit hard for us to do like a big banks of revision questions now when we haven't really gone through like the rest of the content. But yeah, definitely once we get closer, like after mid-sem break, like faculty will start churning out more questions as well. Like you'll have like what's it called again? Like the summative quiz, or like do you have like they do like a formative thing, and then they do one that actually counts, and then they do like another puzzle thing. There's like faculty does like quite a lot.
Actually, I just checked. You can actually access. Okay, I wouldn't recommend this at this time of the semester. But if you're somehow feeling super keen and want to start on exams already, you can access them. You can access them at Equella, equella.monash.edu, which I'll chuck in the chat. And this will have like your Med 11, it'll have the old unit exam, so your Med 1022 exams. I would just be careful about these because with the unit change, there was a change in content and like how they teach it, as well as some of the questions you just haven't learned the content for.
Yeah, they had like quite heavy embryology back then, and we don't.
Yeah.
Yeah.
But if you're super
Until
keen,
later.
you can have a look at those questions. But honestly, there aren't that many questions, so I would probably save these exams till later.
Yeah, you should save all your practice exams till the end, I would say. And also like the distribution of like resources, especially like quizzes and questions, is a little bit dodgy at times. So normally you should just wait for Akil. He will definitely send out a bunch of links closer to your exam date with all the resources that you can access. So that this includes things like past PSPs, and practice exams, and random worksheet questions. Yeah, Akil will be in charge of that. And if you really have any questions about this at this stage, I would recommend chucking Akil an email.
Yeah. Or
although he's probably pretty busy.
Yeah, once you get your own year 1 academic rep, just ask them. But yeah, Akil is your current go-to person.
Be nice to Akil. He is a legend.
Yeah, he does.
Yeah.
He probably does too much. So please be nice to him. Yeah.
But that's about it.
Thank you.
Yeah, no worries. Cool. Okay, we'll wrap it up there then. Sweet.
Yeah.
All right. See you guys.
Bye,
We'll figure out
guys.
next time
Bye.
for stuff.
Yeah. Bye.